I've done a little bit in the patrol division where I work the road. And for the last 2 years, I've had the opportunity to work in the Omaha area working investigations, primarily focused in pharmaceutical diversion. I'm going to let my partner here introduce himself as well. He's going to be helping me with the presentation.
Yeah, I'm Tyler Conkey, an investigator, doing pharmaceutical diversion investigations as well. Me and John work out of the same office. I'm assigned to the DEA task force doing more of the federal type crimes and those types of investigations. I've been on the patrol for 11 years, worked traffic as well with John down in Lincoln, and then moved into pharmaceutical diversion stuff for the last few years.
So we're going to kind of get into this, but first things first, I always like to emphasize that we're dealing with people like yourselves that are the subject matter experts. We try to pretend like we know all the answers, but of course, we're going to give you our perspective. Feel free to contact the administrator that's putting on the presentation. If you have any follow-up questions, they're going to have our contact info. Please let us know. If we don't have an answer, we'll try to find one for you. We'll get back to you. Biggest thing is, I wanted to emphasize is I tend to learn as much from you guys as you do from us in these presentations. So I like an open dialogue. Anything you can give, any feedback, it's always great. But we're going to jump right in. Got to start off with the fun stuff first, like we usually do in law enforcement. There's always going to be attorneys jumping in. This is just our legal advisement, basically saying this is our opinions and our outlook on the trends. And what we say is not going to necessarily always carry over into what your particular agency guidelines might follow. So we're going to give you our information, but definitely if you have any questions, concerns, always make sure that you're consulting with your own legal division as well. We have a couple of objectives here. I'm going to just cover. We want to summarize how prescription medications contribute to the opioid epidemic. We want to describe instances of drug diversion, and we're going to also list drug diversion preventative measures to utilize in pharmacy workflow. So everybody loves statistics. We start off with this one because it's actually pretty shocking when you see the United States consists of approximately only 5% of the world's population. However, we're overachieving. If you look at hydrocodone consumed, we're consuming 99% of the world's hydrocodone and 85% of the oxy. And when you come to new heroin abusers that start with opioids, it's up to 80%. So we're definitely leading the pack here when it comes to problems with the opioid crisis. Again, more statistics, just things to kind of wrap your brain around what we're actually dealing with here. I'm not going to go through all of these, but I will want to touch on a few of them. Now, these are statistics that were recorded in 2019, and one of the ones that I really like to point out here is the top left corner. It's 70,630 people have died from overdose in 2019. Now, everybody always goes up on their soapbox and preaches about how the opioid crisis is extremely bad, but I don't think we really truly understand it. Now, if you were to break that down by day, that's roughly 191 people that die from overdose deaths daily. And to translate that into real world numbers, consider this that your standard Boeing 737 jet, that's going to hold 188 people. So figure on every single day, one of those jetliners crashing, everybody on board passing away from the disaster. Now, if that happened, I can guarantee you there isn't a news station across the country that wouldn't be covering that. but how many times are you actually hearing about the overdose crisis that we're experiencing in the United States? Also, over here, we're talking about the likeliness of users turning from legal to illicit drugs. You got people that are addicted to alcohol, marijuana, cocaine are only 2 to 15%, 2 to 15 times more likely to be addicted to heroin, whereas a person that might get started on, say, any prescription opiates is actually up to 40 times more likely. So just to kind of give you an idea of how addictive the nature of the opiates are and what people tend to turn to when they can't get their prescription meds.
So this chart just shows us how we got here. We got here with prescription opioids, and everyone's heard about Purdue Pharma and the overprescribing that they did with OxyContin back in the mid '90s, and the marketing campaigns that they had then. We saw a steady increase of overdoses due to prescription opioids, but lately that's not what we're seeing. It's going down actually, but yet our overdoses continue to rise from opioids in general, illicit and legal, and they're rising at an alarming rate. So we've noticed that we had a problem with prescription opioids and it led to overdoses, but that's tapered off because we're dealing with doctors, pharmacies, that type of stuff where people are educated. But it's turning to an illicit side. It's turning to illicit opioids. Fentanyl is huge. Fentanyl is in almost any drug that's out there now. That's what it's laced with. And people think that they're taking cocaine or they're taking meth, and it ends up being laced with fentanyl. We actually have seen marijuana laced with fentanyl now. So you just don't really know what you're getting. We have the pressed fentanyl. We'll cover that later. But just to show you that prescription opioids are going down as far as the number of overdoses due to them, but yet we're still rising in overdoses. Thank you. Some of the prescription drugs, these are the most commonly abused that we see, and I think as far as CDC as well, your hydrocodones, your oxycodones, those are your Schedule II opioids, Xanax, Tramadol, Zolpidem, clonazepam, lorazepam, all your PAMs, dextroamphetamine, your ADHD medication. This is one that in Nebraska that we see more than anything, and that's the codeine or lean type of stuff. And then again, your ADHD medications. Codeine hammers us all the time, and that's one of the biggest ones that we deal with pharmacists on as far as fraud coming into the pharmacy and trying to get that. What is drug diversion? When we talk about drug diversion, a lot of people, especially cops and other people in the public, think of, court drug diversion or diversion where you get arrested and you can actually go through a substance abuse program and you get the charges dismissed, some type of diversion in court. What we define drug diversion is any criminal act or deviation that removes a prescription drug from its intended path from the manufacturer, where it's legal, to the intended patient. So yes, prescription opioids, prescription drugs in general have their uses, they have their medical uses, but somewhere in that chain from being manufactured to the actual end user, it gets diverted through fraud, through theft, through burglaries, whatever it may be, and into somebody that it isn't needing it and is getting it for illicit reasons. Prescription drug diversion involves the unlawful channeling of regulated pharmaceuticals from legal sources to the illicit marketplace. And it can occur at all points in the drug delivery process, from the original manufacturing site to the wholesale distributor, to the physician's office, the retail pharmacy, or the patient. It happens here. We have one of the lowest overdose rates in the entire country, but we definitely still see a lot of drug diversion here. There's just some headlines as you see across the country. It happens all over.
Okay, so why are we dealing with problems with prescription drugs? And I think Tyler kind of touched on it actually, the likelihood of detection. These are legal medications at one point, and so when you see somebody walking down the street that is, say, carrying a prescription bottle, you're really not too concerned about it because the majority of the time that person probably did go see a healthcare provider, did provide a statement for symptoms, was prescribed medication, went to the pharmacy, paid, used insurance, everything was up on the level. However, there's probably another person walking down the street with another prescription bottle that was illegally obtained. How are you going to know the difference? If I saw somebody with let's say a crack pipe and was smoking right next to him, I know right away that was illegal, but not necessarily when it comes to prescription medication. So people tend to like the diverting prescription drugs because it's not necessarily as likely that they're going to get caught. It's a little bit more difficult of a process to figure that out. Also, there are 13,000 registrants in Nebraska, and I know we're dealing with a lot of people that are outside of Nebraska. We haven't gotten the numbers, we're just giving you what we know from around here, but 13,000 registrants basically is 13,000 people that are able to prescribe drugs that addicts could divert from. That's a lot of, I don't like to use the word drug dealers, but when it's an addict, that's what they look at a provider as, is they're a drug dealer. So that's a lot of people that they can get their medicine from. The lack of knowledge and awareness, and I kind of spoke to that already. When I was working the road and I saw a bag of methamphetamine sitting in the center console, I knew right away that is illegal. This person's going to jail. But if I saw somebody that maybe was doctor shopping, but all they had was that one prescription bottle, I wouldn't know any different. The law enforcement has a tougher time identifying the person that's doing the diversion of prescription meds. And for the prescription drug monitoring program, now we threw that in there because it's, for us at least in the state of Nebraska, we have had it for a little while now, but it's still relatively new and in its infancy for us. We've had it since 2017. It's an invaluable tool to use, and I definitely stress anytime you have the opportunity to check some information through there, you always do. But without that resource a few years back, you wouldn't be able to identify people that were going from place to place, multiple doctors and their prescription history. We just didn't have that information. So that was holding us back. Now we do. Now we're much better off. So we're gonna roll it. And then another reason why we see a lot of diverting with prescription drugs. So it's all about money. I personally think that every crime committed that I've dealt with generally has some sort of tie back to money, and diversion is no stranger to that. It's a low cost, big reward kind of a field. And we will get into this a little bit more, but Tyler had referenced the codeine, primarily promethazine with codeine cough syrup. We see so many diversion reports on that. And the reason is because you can walk in and for $40 you can get a bottle of promethazine with codeine, and in the right market, you can take that out to California, you can make that $40 investment turn into $3,000, $2,800 in Texas. Only 7 hours away in Chicago, you could get $2,500 for that same bottle. And now when you consider that they're doing multiple pharmacies at a shot, you could walk out maybe 5 different locations and you're ending up with over $10,000 profit. That's pretty good justification to a lot of criminal organizations as to why they need to get into the game. More representation of the markup in medications, those pills at the pharmacy that you see that are pennies on the dollar, street value goes way up. And if you can get somebody to go in and say that they got a sore back and they need oxycodone, and then they'll sell it to you for $100, and they turn around and sell it for $20, $30 a pill. You know, it makes a big difference. So it's just more, it's all about money, really, when it comes to the criminal organizations.
So the clientele that we're looking at here that deal with pharmaceutical diversion, one, especially with the coding, we see our criminal organizations. We've seen it also with the oxycodone scripts. That's getting less and less because pharmacists and doctors are picking up on the oxycodone. They just kind of become suspicious of it because it's been beat in their head so much about that. But coding, definitely almost every organization that we see come in and trying to get fraudulent coding scripts are a criminal organization. And there's reasons behind that, not only the profit, but it's a Schedule 5 drug, so you have to get a boatload of it for the feds to even take it serious and prosecute them, and they know that. And on the state level, the crime is just not, it's not heavy-handed enough for them to be concerned about getting caught. But you see out-of-state licenses on these scripts that are coming in. It's a new patient that the pharmacy has not seen before. We're creatures of habit. Usually we're in the system unless we just moved there. But I'm not driving to Chicago to fill my prescriptions. There's no reason that they should drive here to fill theirs. Showing up near closing time or on weekends. This is a big one. Actually, on jail phone calls we were listening to on one of the individuals we arrested, they talked about how don't come in until after 5 because then they can't call the clinic to verify the prescription. Thanksgiving weekend, we got hammered by a criminal organization. They were here over the whole entire weekend after Thanksgiving and just hammered the fraudulent prescriptions. The other side of the aisle, besides these criminal organizations, we deal with individuals that are addicts. They're your doctor shoppers. They're an employee at the medical clinic or the doctor's office. They might be the doctor themselves. We've seen dentists. These prescriptions know no boundaries as far as addiction goes, and it can affect anybody. It can affect pharmacists, pharmacy techs, all that. And they'll, like the other person will alter a script. You know, they'll take it and they'll put they'll change a 1 into a 3 and try to get more, and they'll do requests for early refills. We treat these completely different when we're dealing with them on the side of the road. Criminal organizations, these people do need to go to jail. The individuals that are addicts, it's more of let's try to get you some help and make sure that this isn't a continuing trend for them. The different methods, what we see, burglaries, this had died down for a little while and just picked up recently where late night when the pharmacies close, they're breaking in, forced entry, stealing from the pharmacies themselves. That's happened more and more, especially out in the rural areas of the country, just because there's just not a lot of law enforcement. Not all the time their cameras are up to date, but also residences. Almost everybody's got a prescription in their medicine cabinet in their house somewhere that they've gotten left over from tooth filling. And when you're talking $30 a pill for some of these things, you don't have to get too many before it's really a nice reward for them. And not only a nice reward, but they may be doing it and seeking it in a drug behavior or a drug addiction way and just trying to use. Theft, internal, doctors, pharmacists, nurse, we've seen them all.
Well, not pharmacists, I would never.
Not a pharmacist.
No, a pharmacist.
I think that was only my second case I ever worked, but it affects everybody. And
we don't want to offend our crowd.
Yeah. Some of the doctors, I mean, we've seen one of the cases I worked was an orthopedic surgeon that was writing scripts to her friends and then going and filling them herself. And she was addicted, so she gave up a couple $100,000 a year job because of her addiction. So external, the medical supply delivery companies, the companies that go out and deliver controlled substances to the nursing homes, and that type of stuff. We see the delivery drivers that have an addiction and end up doing that, or they do it for profit as well. The fraud that's involved, that's a big one that we deal the most with, I would say. Your phony call-ins, they act like the nurse at the doctor's office, and they're calling in a script for Dr. Steve, and then they give the patient's information. They usually have a pretty good script that they have, and then if you ask a few questions, they don't have the answers to it. So,
And this one's actually kind of tricky too, because we get people calling into pharmacies quite a bit with, like Tyler said, a very good script because they're told exactly what to say. And sometimes I've even had pharmacists that I talked to after the reports come in that said they were good, but they were almost too good. Like they were volunteering information that I hadn't even asked for. That's because all they know is to go down their script. And it's up to you guys to be able to identify that. Sometimes I had a report where somebody called in and they asked for the MPI number from the provider, and the doctor said that he forgot and he didn't know how to get that information. So they can be pretty bad, but sometimes they can be over the top good. Just, you guys deal with it on a daily basis. We're trusting that you do a great job and you'll continue to do so. But
the next type of fraud is the fraudulent prescription pad, the paper that comes in. You can order this off Amazon. If you're on Amazon right now, you can order actual legitimate prescription paper, and then you just have to know your outline of how you want to use it, the template that a doctor's office would use. Get the doctor's DEA number, and they're printing these off. Not only that, they're faxing them. They'll fax it over, and it's a legitimate looking template that they use. Now, January 1, at least in the state of Nebraska, and I know other states are doing this as well. We're going to just electronic scripts, but there's a lot of exemptions in our state statute that allow the pharmacy to fill that prescription based off of the doctor's office's computer programs down or whatever it may be. And the pharmacy does not have to verify that exemption. So we're going to continue to still see the fraudulent prescription pad, even with us moving to just purely electronic scripts. Also, fraud is the doctor shoppers. They'll use different names, different addresses. The PDMP does a pretty good job of connecting those when you look at them, but not always. They'll come in with the name James and then Jim and then Jimmy and then kind of just change it up just to throw them off a little bit. They'll use their kids' names, their sisters' names. That when you're addicted, you do some things that are just outside of your element that are not like that person, and that may be one of them, using family members' names. And then they lie. They go to a doctor and say, I'm not on any prescription medications. I'm not seeing any doctors, but yet really they actually saw a doctor about 2 hours prior to that. So forgery, touching on that a little bit, the altered prescriptions this is just easier when you have a paper prescription to where you can change it. You can try to change some numbers to look at early refills. We've all been doing it on our homework for the past 30 plus years, so we all know what that's like to try to change that B into an A or C into a B, whatever it may be. They're doing the same thing. It's just sometimes it's really bad. They'll use different colored ink, and sometimes it's even been filled, which is even worse, I think. This is the small minority, but it still does happen. Is your improper prescribing by your doctors, the doctors that aren't taking the patient's care and well-being in the mind, and they're giving them any type of medicine that they're wanting. And this isn't always that the doctor's bad or the doctor is just a pill mill. Sometimes if you get a person that's very pushy and very demanding, they're just almost afraid of that conflict, and they don't want to tell that person no. They want to make their patient happy.
And I had an investigation that kind of went along these lines. It was a general practitioner, and he had a patient that had a bone density issue, so multiple surgeries, almost in constant pain, and she was being prescribed tramadol, and he was trying to control the different levels of pain for her and changing the dosage and whatnot. And when I spoke with him, he said that he was aware she had a problem. He was just trying to help her wean off of it. And I asked if he had ever referred her to a pain clinic or anything like that. He said, no, I'm just going to try to help her myself. And this was going on for years. At a certain point, if it's not fixing the problem, maybe we need to kind of outsource it. So I don't think in that respect the doctor was intentionally trying to do anything wrong, but in the meantime, he acknowledged that he had a patient that was an addict, and He just kept feeding the addiction, thinking that he was doing the right thing. So it can be sometimes out of negligence, sometimes intentional, but we see it all.
The last one there is medical identity theft, sharing or stealing someone else's information. That information can be found on the dark web, and they'll steal names, date of births. A lot of times I would say this deals with the doctor's information. They steal the doctor's DEA numbers, they steal the doctor's private information, and then they can write prescriptions off of that stuff. And it's really, with e-scripts, the fraud that we're seeing, I would say, is more tied to this, of them hacking information and then using it in order to get into these electronic health records and be able to prescribe from those. They'll create fake information all the time. Every patient that we see on the coding scripts are usually not a legitimate person, not a legitimate address. The phone numbers on top of the scripts are actually spoofed, and it's not the actual doctor or the medical clinic's phone number. If you would call it, somebody may answer and say it's a legitimate script, but it probably is the individual that made the fraudulent script. Fraudulent billing, that usually deals with Medicare and Medicaid. We see that when they're either brand name to generic type of drugs. Also, just how long the office visit was and the different coding with that. Electronic prescribing, this is new for us. It's the newest trend. They're stealing the doctor's information and be able to sign up through the EMR, where they have their vetting process in order to get an account. There's multiple EMRs that a doctor can sign up for, and then it all goes through a clearinghouse, I would say, before it goes to the pharmacy. But if they steal the doctor's information and they have that stuff, certain EMRs will allow them to set up an account, and then they'll be able to prescribe from that electronic prescribing system. And we're seeing more and more of that. I think Nebraska's probably cutting edge on actually investigating some of these cases, because we went to a conference and not really anybody had seen a whole lot of it just yet, but that's going to be the way, because they're not going to stop, and this is what we're moving to with the e-prescriptions.
And I can't stress enough how important it is to really be focusing on those scripts too, because I believe anyways that it can be real easy to assume that since an e-script had to come from a doctor through the electronic medical record, through the clearinghouse, and then to a pharmacy, it passes so many levels of security and scrutiny that as a pharmacist, you see that and you automatically assume it's got to be good. It's been vetted so many times. So you just go ahead and fill it. I'm really wanting to stress now more than ever, it is very important to give that script the look just like you would if it were a paper script or something off the fax machine. It's really important. You're still going to see that even though it was electronically prescribed, it still could have that doctor in Colorado prescribing for a patient out of Louisiana, and they're filling it in Omaha, Nebraska. Just because it's on an e-script doesn't necessarily mean that that's legit. Just make sure that you stay on top of your game, still scrutinize those electronic scripts just like you would anything else.
This was pandemic related, I would say, the increase in telehealth prescribing and the fraud there. There is limited identification if anybody's ever done it on what you require as a patient to sign up for this and go through that process. So there's going to be some fraud, doctor shopping almost involved there. The dark web, it's a one-stop shop. You can order anything you like. Bet you almost any kid that you can talk to almost knows how to get there. It's hard to track down, and it's shipped right to your doorstep. The problem that we see is like these. This was a case that we worked. These are M30s. They're oxycodone 30 milligram tablets that a online pharmacy was selling. We get them, and you can kind of see that they are not legitimate once you get there. They're breaking in half. They're kind of powdering off. They're just not that professional drug that you would see if you actually got it from the manufacturer. These turned out to be heroin. That was a couple of years ago, but anything M30 now we see is almost purely fentanyl. And you don't have the professionalism. This is some Joe in the basement in whatever foreign country he's at, trying to press this, and you may get one pill of all fentanyl and then one pill of nothing, and you just don't know what you're getting. You want to be covered, or you want? Go ahead.
Yeah, I can kick in here. Okay, so illicit opioids, heroin, obviously, it's more affordable than prescriptions. When people tend to run into the problem where they had that back surgery, they were prescribed hydro or oxy or tramadol, and they can no longer get it. Either cost too much, or the doctor has decided, look, you're at a dangerous point, we need to cut you off. Where are they going to get that, take care of that addiction? And so they tend to turn to the heroin just because of its affordability. And now even more so, we're seeing, like Tyler alluded to, is fentanyl, because that black market fentanyl that you can get shipped over, it gets pressed into pills. We're seeing it so much more, and the level of danger that is associated with it, the amount of overdoses that we're seeing because of it, is a very shocking and alarming stat. You all are probably aware of the potency, but we have listed 30 to 50 times more potent than heroin, 50 to 100 times more potent than morphine. It does not take a whole lot to make the mistake, have that one pill that maybe had a little bit too much heroin or fentanyl cut into it, and then we're dealing with an overdose rather than just getting your high. You see a lot out of Mexico. You see a lot out of China. Tyler had talked about the black market. That's your gateway to be able to get this stuff shipped right to your doorstep. It's way too easy now.
DEA's talked about the majority of this, your chemicals that are making fentanyl are being shipped from China to Mexico and then up through our southern border to be in the United States. And that's, the cartels are shifting towards that because they can transport this in smaller quantities with less likelihood of detection and greater profit margin. And this is just what we're being more and more addicted to. So this is supply and demand at your finest. So that's just covering carfentanil, fentanyl. Those granulars are the equivalent of what you see in the heroin at the end there.
So,
and these just a very, very small amount takes for you to. That's a lethal dose, and carfentanil was made to be an elephant tranquilizer, so it was not intended for a human to consume. And the fentanyls, there's so many analogs now too that we're seeing that it's just being harder to detect for everybody as well. So it's a very, very small amount of fentanyl that can be lethal.
Okay, so pharmacy indicators, things that we want you to pay special attention to. A person walks in, you ask for ID, they don't have it, it's in the car. It could be, but 9 times out of 10, you're probably going to be carrying that with you. So people that don't want to be identified are going to leave it outside, just not have it when you're ready to ask for them. People that have the propensity to pay with a good RX or in cash alone, and that could be for a number of reasons. Maybe their insurance won't pay for the next refill because it's too early to be processed, their insurance. So they say, well, that's okay. I'll just pay in cash for this one. That's a red flag. That's something to make sure you take note of. Or they're doing it as part of the criminal organizations. Those guys don't have commercial insurance for all the fake patient names that they've got. So, of course, they're going to be paying with those good RX cards or in cash. If it's a new patient, not in your system, I know the pharmacist that has prescribed every medication for me for the last probably 15 to 20 years. We have a good working relationship now more than ever, now that he knows what I do for a living. But I don't go to a whole bunch of different pharmacies and start new profiles. I go to one particular place. They get familiar with me. new patients at the pharmacy. It's another thing to keep your eyes open to, something that you should be alerted to.
And not only patients at the pharmacy, but patients in the PDMP too. Like in Nebraska, which talks to many other states, PDMP, they log all prescriptions, controlled and non-controlled prescriptions that come through their pharmacies. So if you have a 50-year-old patient in the last 4 years that's never gotten a prescription, then the likelihood of that is very low. I would consider myself a fairly healthy person that doesn't go to the doctor that often. A little overweight, but that's different. But I still got a prescription for something in the past 4 years since the PDMP's been in implementation here in Nebraska. And so I'm even in the PDMP there, and I don't get a prescription once a year, maybe once every 2 years. So that it's not only a new patient in the pharmacy, but a new patient in the PDMP.
Yeah, and that also ties into the no regular pharmacy. This is what you'll find out if you utilize that tool with that PDMP, because you can pull it up and you can say, well, looks like Joe Smith why is he filling at Walgreens, CVS, then he went over to Baker's Pharmacy, and now he's back at the original Walgreens, but now he's going to a different Walgreens the next month. They're just all over the map. It's like I said, I go to the same pharmacy because I want that familiarity with the pharmacist, so he knows what I should be receiving and who to communicate with, who my family members are. These people want anonymity. They will bounce around a lot like that. You can find all that out by pulling up their PDMP profile. It's again, very good resource. Not living near the pharmacy, so I don't think that we have the slide in this presentation. I wish we did, but we have an instance where a person is marked on the map as where their residence is located, and then we show where they had filled a prescription. And along the quickest route to the pharmacy, you pass by 11 different Walgreens, and they went to the Walgreens all the way across town. In your brain, try to process that. Why would they do that? I don't want to drive 30 minutes when I can drive 5. It just doesn't make sense. So might be something going on there. If they say that they have allergies to lesser medications, and this kind of ties into like anybody that comes in and asks for specifics. If they say, no, I don't like this kind of generic, I want the name brand stuff. Not too many people have preferences when it comes to medication. All they want is to be able to take it and get better. They're not looking for the kind that might give them a little bit better high. They'll take whatever you think is best, not give you the recommendation. Another thing to be cautious of. Symptoms don't match the observations. Pretty simple to figure out why we would want you to be alerted to that. Refuse alternative treatments or supplemental exams. That's pretty much just going to be like, if I could do physical therapy, or a surgery, but I would just rather deal with my back problem by taking more opiates. It's just not. It's something that you'll want to take note of. This one that came near closing time on weekends. We already had mentioned to you about that. This is simply because you can't verify with a clinic if it's closed. You can maybe call the on-call, and they might be able to help you, but it's probably somebody that didn't even see the patient that particular day, doesn't really know, and might be making an assumption. And then they flip it back to you, the pharmacist, to make the best judgment call that you can at that time. And I don't really like to rely on just that. I'd rather talk to the doctor and get the yay or nay on that for sure. But the other thing on it too is they are kind of relying on the pharmacist to maybe they're gonna, you think that they might be agitated if you say, well, I can't get a hold of the doctor to verify this, so I don't think I can fill this, and then they're gonna get angry. So you're like, okay, well, maybe I'll just fill it this one time. Well, that's what they wanted. The one thing you can do, and you do whatever you think is best for the situation, but say somebody comes in right at closing time, well, I can't get a hold of the provider, but what if I just got you through the night so that we can call them the next morning, and then if they say yes, then we'll fill the rest of the medication. That way you're helping them, but you're not giving them like 90 pills when you can give them 3. But ways around it, but these are all just indicators that we want you to be cautious and mindful of. Preventative measures, we want you to trust your instincts. You guys are in there on a daily basis. You see a lot of these different scenarios that Tyler and I are laying out. You know what's best. If you feel like there's something that's just not jiving with the situation, throw the anchor out, do a little bit of research. If you can't fill it because you just don't feel right, that's fine. Trust yourself. If you can check ID, there's not always a requirement to check a photo ID, but if you want to, if it makes you feel better, why not? And if you want to make a photocopy so you have a reference for it later, that's okay too. There's nothing illegal about it. I would check with your company policies or legal division and just make sure you're doing everything how they want you to. But I always like this just because it helps me. If you need to talk to us later on, we know who actually came into the pharmacy. Examining the documents presented, that's pretty self-explanatory. Checking with previous doctors, calling to confirm prescriptions. You can do these things, again, previous doctors, you go through that PDMP, you figure out where they've been getting fills from. You can call them, ask them, why are they not going to see you anymore? Why did they go to a different doctor? You'll get the explanation, and it'll help you make a better determination on whether or not you should be filling the script. Only using small quantities of medication. I talked about that. We see a lot of the promethazine with codeine, fraudulent scripts. It is highly utilized in the illicit market in a drug called lean. And people are coming in for 300 mLs. Sometimes they even ask for the full pint, the 473. That's a ridiculous amount to be dispensing. Nobody would need that much unless you've got a cough that you plan on lasting you over a month. In which case you probably better be seeking alternative measures. But if they come in and they're just raising all kinds of cane, wanting that script filled, even though you can't verify it, hey, give them enough to get them through the night, like I said. We'll see them tomorrow when the doctor's office opens, and we'll call and verify then. Keeping accurate records. That's the only way you're going to be able to just document. That way, if you need to reference it later, you can. If you need to talk to law enforcement, you'll have all your ducks in a row for when we come asking questions. It's just coming from a group that writes reports when we go get a cup of coffee, just so we can keep track of everything. It's good to have record of it. So if you have to write it down, that's great. Reporting suspicious patients and incidents and utilizing the PDMP. I would say the PDMP is probably my favorite thing. There is so much information on every prescription fill, at least the one out of the state of Nebraska. I'm sure all the different states are going to have some tweaks that are a little bit different here and there. But if you pull that up, you're probably going to, more often than not, figure out right away whether or not it's a legitimate script. So how can you alert law enforcement? You complete a detailed event sheet. Ask for identification if it is mandatory, great. If not, then that's kind of determination you're going to have to make whether or not you want to go ahead and get that, but it always helps. Copy and scan the ID. If they're willing to provide it to you, that way when you talk to us, we know who we're dealing with. We know their address. We know how to look them up later and figure out anything that law enforcement would need about this person just off that ID. Caller ID. This one's kind of been tricky lately because, like Tyler had said, a lot of these criminal organizations are able to spoof the number. There's so many different apps. I can call Tyler right now with the right app, and it would make it look like I'm calling from California when I'm standing 10 feet from him. So caller ID can be a difficult thing, but it's still documented. Take note of it. Let us worry about where that number actually came from down the line, but at least it'll help us help you if you can get that information. Vehicles and any other people that might have been with the person that you suspect of diverting. I would say the majority of the time they're probably by themselves in the pharmacy. I haven't seen too many times where they come in groups because they don't want to make a big scene out of it. But usually what we're seeing is when somebody comes into the pharmacy by themselves and they are with a group, that person's in the car, they're in the parking lot way outside of any kind of video surveillance view. But if they happen to drop them off in front of the store and you can get a description of that vehicle, maybe even a license plate, which would be outstanding, document that, turn it over to us. That is invaluable. Cameras. I don't know what kind of pull you have with any of your pharmacies or facilities, but if you can encourage administrators or management, whoever you're dealing with, to look at their surveillance system, try to get it as upgraded and modern as possible, because I've gone to some places where I can actually read license plates in the parking lot off of vehicles. And then I've gone to other places where it's just blurry, and I mean, we're already dealing with people with masks on with the pandemic. It's already difficult to identify individuals. And then when we get that surveillance footage and you can't make anything out anyways because the camera is from 1995, it doesn't help anybody. So if you can try to get those systems upgraded and then also position them properly. If you have somebody walk up to your counter and there's a camera that's not right in their face, but close enough where we can actually get a good visual of who's standing in front of you, that makes more sense than having it up in the corner angled down where they're 30 feet away. That's really not going to do anybody any good. So make sure that not only you're using good equipment, but putting it in a position where it's going to help you succeed. Preserving evidence. Anytime you call us, everything associated with the incident that you're calling about, bundle it all up in a nice little envelope, set it aside. Don't get rid of it. Don't throw it in the shred bin. Nothing. We need it all. Everything. No matter how insignificant you think. If you take a little note, save it. Even if it's not on the script itself, everything goes in one package and we'll come and deal with it.
On that note too as well, if you can limit the amount of people that have contact with like the paper prescriptions, that'd be great. Other areas of the country have had success with pulling fingerprints off of the prescriptions, and with a lot of these people using fake names, or there's a handler out in the car that's running them around. It'd be nice to be able to identify those individuals that are handling those prescriptions before they get in the pharmacy. But if we have 9 different pharmacy techs and the pharmacist, and then we're just as bad, 6 cops handling it, then it's just harder to get good prints and the prints that we want off of that. So just be able to preserve that and just put it in either a manila envelope or something, just so not everybody's touching that and using their hands.
No.
On that stuff. But
we're as guilty as anybody. You get a really interesting piece of evidence and, I want to look at it, and then pass it to him. And now all of a sudden we've got 10 different people that have held that one fraudulent script, whereas when we try to do that identification, it just complicates the situation so much more. Reporting immediately. if we can get to the problem, it's going to be so much easier for us. And especially with the traveling criminal organizations that we deal with, if we've got them in the pharmacy and you can tell us, get there right now, and we can get them arrested, that's probably our best avenue at dealing with the problem. Because if it's delayed by a significant amount of time, and we're talking like even 30 minutes of a delay, will dramatically reduce our likelihood of being able to be effective with our investigation. Not saying it's impossible, but if we can get somebody arrested in the pharmacy, that's going to be a lot easier, because 9 times out of 10, when we show up and they've already left, there's a good chance that they're alerted to law enforcement presence, they're spooked, and these people that are in town to try to divert from you have probably already checked out of their motels and probably already on their way out of the state before we even were alerted to it. So as soon as you know something's wrong, you call us. And when in doubt, verify. You know, there's certain things I don't even think, like especially with the level of fraudulent diversion with promethazine with codeine, if you don't talk to a provider directly, I wouldn't feel comfortable at this point sending it out. And it's up to you. You guys have to do what you think is best. But if you can verify and the doctor says yes, then you know you are completely covered. There's no judgment involved. You're doing the right thing.
Yeah. So one thing we hear when we go into a lot of pharmacies is people are concerned about HIPAA, and it's understandable. It's kind of been beaten to a lot of people's heads. It's just that I don't think everyone always understands what HIPAA actually covers, and so there's statutory language in most states that cover that. There's exemptions from HIPAA. One of those being if law enforcement comes in and review. There's actually, and I don't think the link's actually active on here to be able to. Maybe it is. I'll try. It's a guide for people with dealing with HIPAA with law enforcement. So just kind of gives a guide for what things are covered, the exemptions that are out there, and what you can give us. The one thing I always say is when we verify that these individuals don't even exist, HIPAA doesn't cover a person that isn't alive or even out there. So in Nebraska, we have the statute 27-504. It says no privilege for physician-patient privilege. There's no privilege in any judicial proceeding regarding unlawfully obtaining or attempting to obtain a controlled substance. So if I came in by fraud and handed a prescription, or I came in as a doctor shopper, and we've shown that, there's that physician-patient privilege goes pretty much out the window. I understand different corporate policies and that type of stuff, and we're more than happy to either give a subpoena if we have to. That's not hard for us to get. We normally don't. If you need a inventory sheet of a receipt to say that we took this prescription, whatever it may be, we're willing to bend over backwards. Just understand what a HIPAA actually does cover. Here's the federal regulation. It covers kind of what HIPAA is, or what private health or information is out there. So, I mean, you guys can read it. It says, permitted to disclose in response to a law enforcement officer request for such information for the purposes of identifying or locating a suspect, fugitive, material witness, or missing person. You guys may disclose the following information. It gives a list there. Except as permitted by items listed above, the covered entity may not disclose for the purposes of identification or location any protected health information related to the individual's DNA or DNA analysis, dental records, typing samples of analysis, which we're never going to ask for that. I don't want their blood type. I don't care about what their doctor said was wrong with them. That's more on the DEA side if they're investigating a bad doctor, not a patient in your pharmacy trying to fill a prescription. I don't care anything about their dental records. I mean, that type of stuff is not what we're going to ask. The most we're going to ask is a copy of the prescription, the ID that they presented, patient profile of what prescriptions have been filled, at your pharmacy. If you check PDMP, we actually have to have a search warrant to access the PDMP. It's not hard to get. If we have the probable cause, DEA can write a subpoena for it. But I may just ask you when I'm in the pharmacy, did you check the PDMP? And then that helps me be able to go, I need to go look at that information. So continue with the federal. A covered entity may disclose to a law enforcement official protected health information that the covered entity believes in good faith constitutes evidence of a criminal conduct that occurred on the premises of the covered entity. So that's any drug diversion really activities that occur at your pharmacy. You may disclose that stuff if you feel like it's part of the crime. And that's in good faith. As you see there, that's the federal regulation talks about good faith. That means that you believe that it constitutes evidence. You may not know for absolute certainty, but if you have good faith that you believe that that's what it is, you're covered in that.
And it was understood by us that not everybody viewing this presentation is going to be out of the state of Nebraska. So the statutes that we had read obviously might not apply to everybody viewing this. So definitely make sure to consult your corporate legal division if you need any further guidance on that.
These federal ones will apply to everybody, but that first one we talked about from Nebraska, most every state, I would say all states have some type of state statute that would address it. It just may be different. These are usually, the wording is pretty consistent across the board, just maybe a few words here and there that have changed. We're going to go to just examples of what some of the fraudulent prescriptions that we've ran across and some resources that we use that maybe better help you understand of what information we may need from you.
So we have a diversion report callback form. What we do here is just have a general basic information, kind of a form that you call law enforcement and you say, I think I've got a diverted script that got faxed over to me. I'm going to probably ask you, okay, I got your pharmacy information. I need to know the prescriber, the patient, if there was a vehicle, any of the prescriptions that were listed. I want to know also, how did they deliver it to you? This one I said it was a fax. Is it e-script? Because, and this is probably more important when it comes to the criminal organizations that are coming in and flooding an area like Omaha. We've gotten one pharmacy will report that they received a fraudulent script. We put out an alert to all the other area pharmacies. And then all of a sudden, they start reporting back saying, we saw the same thing. Well, now I'm going to call and I'm going to document, okay, so Dr. Smith had a patient by this name at this address, and they wanted 300 mLs and a promethazine with codeine and a Z-Pack. And I've got 12 of them that are almost identical with different patient information. It helps us to recognize patterns. But this is just a representation of some of the things that we're going to be asking you when we call back after your initial report.
This is an example of, this is actually from a pharmacy. It's from a case that involved somebody passing oxycodone 30 milligram tablet prescriptions. It was almost like a checklist that they went through to kind of make sure that it was legitimate. And they got it broken into sections, you know. If professional judgment warrants a call to prescriber and they've got 3 check marks on yes, well, they spoofed the number, so they did think they were talking to a pharmacist or the prescriber, and it wasn't legitimate. But just different things of, hey, this is 120 units or more. This probably is a red flag. We just don't see that as much. Cash pay, discount card, yes, yeah, we probably should call on that. So that's just what one pharmacy did, and it seemed to work well, even though we had a lot of yeses there and we still filled that one. So this is a copy of prescription we see quite often. They vary a little bit from each one. With codeine, they usually almost always have a decoy script, the Z-Pack, like John said, penicillin, albuterol inhaler. There's always 2, codeine and then that one. This is penicillin. This is an actual hard copy prescription. Some things to look for on these. So one, the store location that they filled is Walgreens in Fremont, Nebraska. The clinic that they went to is in Lincoln. The address for the patient is in Elkhorn. It's a large amount of codeine, 360 milliliters. And then on November 24th, they say they got prescribed this from a family medicine clinic. Well, if I know that's a few years ago, but they really haven't changed and they are this dumb. I was just talking about we got hammered this Thanksgiving. Well, this was Thanksgiving weekend that time. Not too many family medicine clinics that are open on Thanksgiving Day. So that was actual Thanksgiving. They weren't open that day. Also, there's another part to that. If you look at the phone number right underneath that, they just have small screw-ups where they put a dash right after the parentheses. And just, it doesn't happen usually with an actual legitimate family medicine clinic. They're pretty professional with their prescriptions and stuff. But going back to not living near the pharmacy, it would make no sense for an individual to drive from Elkhorn all the way to Lincoln to go to a family medicine clinic and then drive back to Fremont and then fill out a Walgreens there. You passed up a lot. The likelihood of that all making sense is not very high and should raise your suspicions a little bit. That's coming from an individual that just is making fake prescriptions and they have no general idea of the area and are just throwing things out there and thinking that we're like Chicago and there's suburbs all over and it's no big deal.
And telemedicine is going to kind of throw a wrench into some of this too, because you might be seeing a doctor that could be in Utah, but you're able to be doing the visit online while you're sitting on your couch in Nebraska. So we just, it's not completely uncommon, but something you want to be alerted of.
This is just an example of how legitimate they can look. They know how to write them. They know how they look. This looks fairly professional. They did a lot of these across multiple states. They don't screw up often, but it's just, it has actual legitimate prescription paper.
Two scripts though, two unique scripts, but they almost look exactly the same. This one, this one was a faxed in script. And if you notice, we're dealing with a practice out of Kansas City. We're dealing with a patient that lives in Lincoln, Nebraska. And then the fax number at the top, when Tyler advances, is a 520 area code, which is actually Tucson, Arizona. So they're faxing it not even from where the practice is located.
And then just again, a large amount of code in 360 mLs. It's just, you don't see that too often legitimately.
This is going to be an altered script here. If you notice, it's kind of difficult, so we circled it, but that 15 originally started as a 5, but you see how the 5 and the 15, the ink density is a lot different there. It's really easy to up the dosage that way. This one, I don't know what they were thinking. Doctor writes it in black ink and the patient alters it in blue ink.
They tried to make it say Adderall or something like that, I think is what it was.
Again, an altered script where we circled it. This was originally a 3. You just turn it into an 8. Right up here, we circled the alteration. Now, the pharmacy actually had to call the clinic and ask, was this stapled to any other paper or not? And they said, absolutely not. However, the patient brought it into the pharmacy to make it look like they ripped it off of a page where it was stapled, so that May 31st, 2021 refill date now says May 3rd. And then again, another altered script down here at the bottom. That's 6, June 4th, 2021 is now May 4th, 2021. So they tried to get it a month early.
I'll speed through this. I think we're running out of time. So the reporting and alerting process in Nebraska, this is just specific to us. We're able to send out alerts to all the pharmacies through fax and email as we get them. So that was that report immediately to us so that we can get this out. Because when these crews come into town, they're not going to hit one pharmacy, they're going to hit multiple. So if I get a call from the first one, there's a good chance if we send out an alert that by the time they come in on the next one, that pharmacist has seen our alert, knows it's fake, and once they start getting shut down or we're hot on their trail, they're out of town and we can get them out of our hair for everybody. So it curbs the potential abuse for us, and it does happen here. Many headlines, we see it. We started that reporting alerting process in 2019. We received quite a few alerts. We've created a lot of cases on this. This is our direct lifeline to you guys in the pharmacies, and it's been great for us. There's multiple ways to report. We have our dispatch number. You can fax over to us, email it, or we have an online reporting tool. We will always call you back in that 3 to 5 minute response. The only time we wouldn't is if every one of us is tied up, but that's not very often. The online reporting tool, if you just Google Nebraska State Patrol Drug Diversion, it will pop you up to this site. You fill out the information in this form. It goes directly to a State Patrol investigator like myself or John, or we have another one in our office, or a sergeant that deals with these crimes specifically all the time. So you're going to get somebody that knows what they're talking about. Sometimes that's not always the case. If you just call direct dispatch, you may end up with an officer that works different things and may not know about this stuff.
Fewer links in the chain. You deal directly with us when you go through that.
Here's our number, our fax number, our email, links to where to report that stuff. We're always going to call you back.